All right, well, welcome everybody to our first Learn at Lunch session of 2018. Glad to have you all back with us, and excited to have Dr. Jeff Rich with us again. Just a reminder, it looks like I think all of you have muted yourselves. I appreciate that. It helps eliminate the background noise. But I know that Dr. Rich is going to have some questions for you, and he's going to want you to add your comments along the way as well. So if you have a question or a comment, just unmute yourself and hop in. Otherwise, when Jeff asks for feedback or questions or answers, go ahead and unmute yourself and ask away. So I will be sending out a link after the session. It'll have a link to the. I'll send out an email. It'll have a link to the video as well as the test. So if you want to get your credit, you'll have to take the 6-question test and pass it with a score of at least 75%. So with that, I know Jeff's got some interesting case studies for you. So take it away, Jeff.
Well, thanks, Jeff, for inviting me. I'm excited to be continuing to do these lunch and learn radiology case study times with you guys. These are all fresh cases. A lot of them are so fresh I don't even have follow-up imaging, but this time is designed really not to pound lots of information at you, but to just show you some really interesting cases, get some discussions going, and almost be a hands-on radiology workshop for you. So I'm excited to get your feedback on some of these cases. All right, just as a reminder, the kinds of questions I'll be asking you really are going to be the 4 Ds. We're going to have some cases where I just stop and you unmute yourself and tell me where you think the abnormality is. You don't need to tell me what it is on those kind of detection kind of questions, but just say, I think that the right femoral neck looks strange. And then we'll move on to figure out why it looks strange with the forensics in the description, and then we'll try to figure out what it is. And of course, very importantly, is the decisions. How does this impact our patient care on Monday morning when we go back to work and we look at these pictures? So we'll talk about some of the implications of even making these diagnoses as we go. All right, so let's get started. I'll make sure that I cover everything you need for this 6-question quiz. So when I highlight certain things, make a mental note of it, and then have Jeff send you the quiz and just take it right away and get it done and get your credit. First question: where is the finding? So this is a detection question. It's a tough case, so don't be discouraged right out of the gate. But here is the first case. So this is I'm not going to give you the history at this point. There's a couple of findings here. Okay, there's 2 findings, and I'll be nice and tell you that. Now, don't worry about some of the metal that you're seeing here. That is a mitral valve replacement surgery. So, patient had cardiac surgery. But I want you to focus on in your detection to look at the technical factors, alignment. I want you to look at the bone, and I'm going to let you do that first. I'm going to kind of get this a little bit bigger, and I'll be real nice and blow this up a little bit for you. And look at the bone now, and I want you to compare. Let's say this is right here is T11. I'm going to put 11 there and then expand it again. So that's 11, and I'm going to go like that. Okay, so look at the spinal column. Look at the vertebral bodies on this lateral thoracic view, and I want you to try to pick, if that's T11, which segment looks abnormal to you. So go ahead and unmute yourself and shout out a detection of what level. You don't have to tell me what it is even, but just tell me what level you think is abnormal.
7.
7, so 11, 10, 9. Did I have a guess for 7?
Yes.
Okay, we got a guess for 7, so 11, 10, 9, 8, 7. Any other guesses?
10, 9, 8. Number 8 is one you're on there.
Okay, number 8. We got a vote for 7. Good job on muting yourself, guys. Anybody else want to throw a guess? We got a vote for 7 as being abnormal and 8 being as abnormal. Which other guess? Anything else?
Maybe even both of them.
Okay. All right, fair enough. I agree. I think one of you has gotten this. So 11. Okay, so we've got 11 here. So look at the nice vertebral body height of 11. 10 looks good. 9 looks good. So 11, 10, 9. But then T8, you've got a little bit, now I'm exaggerating the amount of wedging there, but there is some anterior wedging at that segment so 10, 9 of 8. 7 looks pretty good. It looks pretty good still. You've got good anterior vertebral body height. I admit that you can't see much of anything up here because of obliquity of the end plates in relation to the X-ray beam. You would need a spot view to look for abnormalities up there. Okay, so that's the finding. There's slight anterior wedging of T8. Okay, diagnosis, everybody. Unmute yourself. Someone shout it out.
Compression fracture.
Okay, good, good. Now, we're going to talk about compression fractures more in a second, but let's see if you guys can be heroes here and find one more important finding on this film. There is a compression fracture. We'll talk about that, but there's a second finding, and let me give you a hint: technical, alignment, bone, cartilage, soft tissues. The TABCs, that's your detection, flow. And you don't want to get search satisfaction. You don't want to say, hey, I earned my paycheck. I found the compression fracture. I've done my job. No, that's bone. Go to cartilage and soft tissues. Don't get search satisfaction. Look at all 4 corners of the film under detection. And when you do that, can anybody see another finding that you identified that I think is kind of important?
She looks a little hyperkyphotic and maybe osteoporotic.
Yeah, I agree with both of those, that there's some diminished bone density, and I think even the compression fracture is contributing to the kyphosis. Or, yeah, so I agree with those. But there's another finding. Those are our alignment and bone findings. Keep going. Technical, alignment, bone, cartilage, soft tissues, all 4 corners of the film. Anybody else?
Maybe some calcification in the gallbladder or something on that lower corner.
Yes, very good. Very good. Right here, there's a circular calcification right at the edge of collimation within the soft tissues. Yeah. And I like this case because it teaches us to look at all 4 corners of the films and to make sure that we don't just make a finding under the bone and then get satisfied and let it go. And this is anterior to the spine. I don't have a lumbar spine view, but it is on the right. When we question the patient, she has some issues there with gallbladder. This is a gallstone. So there's a compression fracture, a gallstone, increased kyphosis, and diminished bone density, along with cardiac surgery, just on one film. And a lot of people miss this because they're not looking under detection all the way to the end. All right, let me give you guys something by way of review. I'll go quickly here, and I do have a quiz question on this. 3 questions that you ask of every compression fracture. Just spend 3 minutes on this. I'm going to go quickly. So, look, if you're busy, and I know many of you are very busy, you know good and well that you are looking at compression fractures every week. Yes, some of them are old, some of them are this, some of them are that. Not a big deal. Yes, but you're looking at these, and we have to do better than just saying compression fracture. We have to ask 3 questions. Number 1, compression fracture at T8. Let me ask some questions of you. Number 1, are you acute or chronic? That's the first question. Are you acute or chronic? And how you tell is if you have acute compression fracture, you have two signs. I'm drawing a lateral view of a segment, okay? If you have acute compression fracture, number one, you have what's called an anterior step sign. So you've got kind of a nice little edge and a step right on the front of the vertebral body, right there. Second finding is that right underneath the superior end plate, you'll have a white linear zone of impaction. And those two signs, a step sign and that zone of impaction, indicate that it's an acute compression fracture. And if you have a car accident case, or you're trying to figure out if something's related to certain injuries at work, this can be huge on x-ray to see the step and to see the zone. Now, of course, if you can't see it, so if you do see the step and the zone, it is acute 100% of the time. Now, the problem is if you don't see the step or the zone, it still could be acute or chronic. You're just not sure. You need to get an MRI to be sure if you need it, okay? So that's the first question, is it acute or chronic? Second question, okay, compression fracture T8, are you stable or unstable? That's the second question. Are you stable or unstable? Now, how do you know? Well, I'll draw my vertebral body again with a nice compression. There it is, lateral view. Here's how you tell if a compression fracture is stable. Here's the back part of the vertebral body, okay? If only the anterior vertebral body height is involved, but the posterior vertebral body height and the posterior elements are not involved. Only one column, the anterior column, is compressed, but the posterior vertebral body height is the same compared to the levels above and below. It's stable. It's not unstable. It's not going to probably have neurologic sequelae. It's not going to have issues. And it's a stable compression fracture. That's really important. But if the anterior vertebral body height is compressed and the posterior vertebral body height is compressed, if the posterior vertebral body height is down a little bit too, or you've got a little bit of retrolisthesis even. So the segment that's compressed is retro compared to the levels above and below. Even if the posterior vertebral body height is not compressed, you're going to be dealing with an unstable compression fracture. You're dealing with two columns. That's massively important, because if it's unstable, I believe you should get an MRI and make sure there's not a retropulse fragment, make sure the conus medullaris is okay. You know, it's a big deal. There's not a lot of space in the thoracic spine area for that cord. So I think it's a great question to ask, acute or chronic, stable or unstable. It's stable if only one column. It's unstable if there's more than two columns involved. Third question. Are you compression fracture? Are you aggressive or non-aggressive? In other words, are you going to be a regular traumatic compression fracture, or are you going to be a pathologic compression fracture, like there's some sort of metastatic disease or myeloma in there that's replacing the marrow and caused a pathologic compression fracture? And here's how you tell radiographically. I'm just going to give you two ways. Number one, if the anterior vertebral body height and the posterior vertebral body height is compressed the same, in other words, it's almost vertebra plana or a pancake vertebra, I think that's a red flag. I mean, you at least have osteoporosis that's superimposed, that's causing a compression fracture. And again, it's not a normal compression fracture. You've got an underlying condition that it's predisposed. But if you get loss of both anterior and posterior, I think you got to get an MRI, because metastatic disease and myeloma can look like that, and you just don't want to miss it. So I think that's indication of more aggressive if you see loss of both anterior and posterior vertebral body height. And of course, the second, if you see destruction, obviously, if there's destruction of bone, the bone just doesn't look healthy. It looks like there's some moth-eaten bone destruction and a compression or a missing pedicle at that level. Some evidence of destruction, then you got to go non-aggressive. So look, my grandma can see most compression fractures. Not the one I'm showing you on this case, that's tough. But it's not hard to see a compression fracture. But I think where we shine is by asking these questions. Number one, are you acute or chronic? Number two, are you stable or unstable? And number three, are you aggressive or non-aggressive? Does this help a little bit? Any questions or comments before I move on?
Hey, Jeff.
Yes.
So back to the step sign.
Yes.
Is it possible then, if I'm understanding this correct, that there could be no step sign and it could still be acute?
You got it. So let me say that again. It's very important. If you have a step sign and an impaction, a zone of condensation, a white area right under the end plate, then you know that it's acute. I mean, you got a smoking gun on the X-ray. But if you don't see it, you just don't know. It could still be acute, but it could be chronic. And so you have to clinically correlate. Does it hurt right there? Is there trauma? If it hurts right there in trauma, clinically you favor acute. But look, the lawyers are going to debate. The lawyers are going to argue. You would have to get an MRI if you want to be definitive from an imaging standpoint. But look, for only $45, if you can see that step sign in that zone, you got evidence that it's acute. Does that help?
One additional question, doctor.
Yes.
How common is it for you to see non-pathological fractures that manifest themselves with a reduction of the posterior aspect of the vertebral body height?
I've probably seen it probably 7 times in 20 years, but I'm looking at everybody's films.
Okay.
So it's not extremely common. More commonly, you'll see loss of anterior and posterior vertebral body height in the context of osteoporosis.
Okay.
And it looks, and I'll draw it up there, it has more of this kind of an appearance when it's osteoporosis.
Okay.
It has more of this kind of an appearance if it's pathologic from metastatic disease.
Thank you.
Good question. Any other questions on this? All right, so let's move on. And I'm not going to bore you and teach you like this, like more didactic. So sorry about that, but this is kind of important that we kind of review that. All right, next case. This is a interesting case. 53-year-old with right hip pain, very severe, at an onset of pain 2 days ago. Let me tell you the story. So, pretty bad hip pain. So he went into the MD. The MD took an MRI actually of the low back, not the actual hip, because some people kind of get the hip mixed up with the SI joint, as you know. And so remember, obviously, true hip pain is groin pain or even anterior thigh pain. That's true hip pain. He had real hip pain. He didn't have any SI pain, but they kind of goofed up. They took an MRI, and it was read was mild degeneration. They didn't really see anything. So he was like, what's going on? They don't see anything? This is killing me. So he went into the DC. The DC was smart enough to say, look, it hurts in the real hip. So they ordered actual hip x-rays. I think that was wise, and you'll see why. Take a look at this x-ray. And so you can see the right hip and the left hip. The right hip is, of course, marked. So which hip looks abnormal to you, the right or the left?
Right.
Yeah, I mean, guys, what do you think? I mean, do you see the abnormality? Obviously, there is something that makes your heart start beating quickly. Do you agree?
Yes.
Yep, and this was just a week and a half ago, and take a look at it. There's something in the bone, and I'll just circle this whole area is involved. Not so much in the femoral head. I agree that it's not involved there, but now, good detection. And there's an abnormality. It's in the bone. So now we got to think about description, and we got to ask ourselves the question: is this primarily? I'm sorry. Is this going to be if this bone lesion is going to be aggressive or non-aggressive? Aggressive or non-aggressive? That's a huge question here. And I would just, yeah, I agree. So we got people voting for aggressive. And let me go ahead and expand this and show you why I would go, whoop. Come on now. There. Why, if you look at this, the reason that we're going aggressive here is look at the cortex. The cortex is gone. And you guys, if you have cortical breakthrough, cortical breakthrough is most suggestive of an aggressive bone lesion. Cortical breakthrough is most suggestive. I don't care, moth-eaten bone destruction. What's that? If it's big, it doesn't matter. What is really indicative of an aggressive lesion is when you cannot see the cortex clearly. You have to assume it's aggressive in that case. And here I agree with you guys that looks really aggressive. And let me show you the frog leg view of that. Now this guy, you'd say, how could he just have pain for 2 days? Well, as point of fact, he had some dull pain in his hip for quite some time. But why did he have acute pain? I'll tell you why. This is spread up into the supraacetabular region. And so, of course, with weight bearing, I mean, you're probably getting a path fracture through that weight bearing area because it's expanding. And he probably path fractured through it, and probably that's what discovered it. So it's kind of a sad case. And in this age of a patient with a big lesion and bone like this, let me tell you what your diagnosis is. Well, throw out a guess. Aggressive lesion in an older patient, what's your most likely diagnosis?
Metastatic carcinoma from the prostate.
Yeah, yeah. Now I'll tell you that metastatic disease, and let me tell you, this is how many times you'd say metastatic disease. Mets. I did that 24 times. 24 out of 25 of aggressive bone lesions will be metastatic disease. The next one will be multiple myeloma, and then lymphoma. So that's going to be, now this person is a smoker. So where do you think the primary is? The primary cancer is from the lung, so this is lung metastatic disease to the hip most likely. And it's so fresh, I don't have the follow-up yet. Okay? So a pretty humbling case. One of the worst cases I've seen here in a while of aggressive abnormality. Okay, next case, 47-year-old female with hip pain. All right, now we got the left hip and, of course, right hip. All right, this is for you guys. Unmute yourself and play along. Which hip do you think is abnormal here?
Left.
Good. Anybody, any other votes? Everyone agree? Left hip being abnormal?
Yes. Left.
Okay. And why are you saying it's abnormal? Anybody want to play along and give me a little description now of your finding?
Reduction of the joint space and supraacetabular sclerosis.
Okay.
Sclerosis.
Yeah. Good. Good. So if you look at this case, pretty good joint space in the superior compartment, but on the left side, I agree. I mean, look at that. There's pretty good narrowing of the hip there. So this obviously degenerative joint disease of the hip can cause pain. Now, I bet you're seeing something else though, right? In that left hip.
Would you call that an impingement too, with a cam and maybe a little pincer impingement?
Well, I probably would question it because if you look here, do you agree that it's a little more bumpy there?
Yeah.
A little more prominent there, and also there's quite a bit of overhanging. So I would clinically correlate for femoral acetabular impingement, but not super. Remember, femoral acetabular impingement is a clinical diagnosis. I agree. There's X-ray findings that can correlate, but so maybe minimal connection here. But yeah, I think you could raise that possibility. But I bet you're looking at these lines here.
Pinned. Been pinned.
Yep, good. And so good job. This patient had previous intramedular pins or rods or screws from an old fracture through here a long time ago. And so now we know why such a perfectly good hip here, but a bad hip here. Why? Because there's secondary degeneration from old trauma. So good. Here's what I want you to know. Degenerative disease in the hip narrows the superior compartment first and worst. It narrows the superior compartment most, and that makes sense because by Wolff's law, you're going to pound that superior compartment. All right, nice case. You guys are batting 1,000 here, finding the findings on this. Even that nice gallstone. All right, next case. 50-year-old with a motor vehicle accident and rib pain. All right, this one I need to go quickly through so I can get to the other cases for the quiz, okay? So let's not spend a lot of time on this one. But, all right, this is a Where's Waldo case. I'm going to make you make 2 findings. So unmute yourself and make the findings. Don't get search satisfaction. Look at all corners of the films. And let me remind you, there's rib pain. All right, go for it. Tell me where the 2 big findings are. As soon as you get it, we'll move on.
Left T10.
All right, so this is going to be the air bubble. So we'll go left, right. The rib pain's on the right.
That would be right T10.
Good. So 12, 11, and very good. It's at the corner, but there is our rib fracture. Everyone see it? And I think, and I like to blow this up a little bit, show you. I think if you look at it, it's pretty well defined. So probably more of a subacute to chronic rib fracture, but sometimes it's hard to tell, but I think it's got pretty well defined margins. All right, that's one finding. But what else is going on here? Yes, there's some osteophytes. Yes, there's a curve.
Left hip.
What else? Yes.
Left hip.
Left or right hip?
You're right. You're right.
So, well, I do agree that it's a little narrow, mild on that left hip, but look at the other hip.
I meant right hip.
Yeah, oh, good. Isn't that nasty, guys?
Yeah.
So here we are looking for a rib fracture, which is fine, but that hip is the worst finding. And that hip, that is nasty. That's bone on bone. That's lateral subluxation. That's flattening of that femoral head. That's subchondral sclerosis. I'm getting feedback. Are you guys getting that?
Yeah. Just make sure you mute yourself.
I'm just wondering if it's me.
No.
Oh, no, it's gone now. Everyone hear me okay?
Yeah, we all got to be a
Okay.
little more dynamic with our mute and unmute and mute and unmute. So when you're talking, unmute. If you're not, mute.
Yeah, and I apologize. I get kind of loud and obnoxious. I probably blew my speakers out over here. I apologize for that. So we've got some good degeneration. All right, let's move on. Next case is a 32-year-old female with low back pain. All right, detection.
Sacroiliac bilateral, worst on the left.
Nice. I agree. Good pickup. The SI joints are the big abnormality. You see, look around the pelvis a little more. You see another finding around the pelvis at the other joint, the other main, kind of look at another joint area.
Lumbosacral juxtaarticular sclerosis there.
Yeah, there's some changes there, but also I was just noticing, take a look at that symphysis. There's some pretty big lucencies around the symphysis pubis. So in the ring, you've got the SI problems. You got also some problems in the symphysis pubis here. Now, if I were to tell you that the SIs themselves, now watch this. Whoops, let me get back to that. I want to blow that up for you. See if I can. Look at the inferior aspect of the SI joint on the viewing right. Now, those big normal paraodontoid grooves there, just ignore those. But look at the inferior joint. It doesn't look eroded. It doesn't look wide. So the joints aren't that bad, but what you do have is a triangular region of sclerosis there. Triangular region of sclerosis. And you have cysts in the symphysis pubis. Now, this person has had multiple childbirths. So, any thoughts of a condition that could give triangular sclerosis of the SI joints following the context of stress to the pelvis? Of course, probably created some of these subchondral cysts as well in the symphysis pubis. Anybody remember that condition? Diagnosis, let's slam dunk it. Anybody got one for me?
Chronic sacroiliitis.
Okay, so differential is sacroiliitis.
Osteitis condensans ilii.
Osteitis condensans. Okay, good. That's a great differential. And under the sacroiliitis, if you're getting bilateral symmetric changes in AS or enteropathic arthropathy, but I like AS if that were the case. If you had more bilateral but asymmetric appearance, then another seronegative spondyloarthropathy such as psoriatic or Reiter's disease, remember that one? Also called reactive arthritis. So that'd be a differential, but it is not sacroiliitis because the SI joints are okay. There's no widening or erosion or indistinct appearance of the SI joints. You only have the sclerosis, and it's triangular. So that leads us to osteitis condensans ilii here, especially in the context of multiple childbirth. So that's great. You nailed another diagnosis. Osteitis condensans ilii gives you that triangular region of sclerosis after childbirth. And I like it because I wanted to remind you that you can see this with leg length discrepancy. If you get about 1.5 centimeters of leg length discrepancy, I almost guarantee you that you're going to throw out abnormal stress-related X-ray changes in the SI joints. We need to start looking for this. I think that they're related, and I think we need to do some research on this in the chiropractic colleges, because I think if you have SI pain in the context of leg length discrepancy, you would get an MRI. Now, I'm not saying get the MRI, but if you had it, you would see marrow edema. And if you're familiar with modic reactive in-plate disease, inflammatory in-plate disease and degenerative change, we'll have to talk about that another time. This, I think, in the SI joints with leg length discrepancy, when it's significant, if the person's active, you can almost get modic changes in the SI. And I think this fundamentally puts us on the map in regards to biomechanical analysis and chiropractic, and help prove that what we do is important. I get excited about this biomechanical research when it comes to the bone marrow changes. And so when you have the triangular sclerosis, you guys, that's really in stage, the Wolff's Law, the body's thrown down, sclerosis trying to stabilize that. Well, what if we got at this earlier before we threw that down and created degenerative changes? Well, then we would have our smoking gun. We would have our cavity, our subluxation. We'd have our finding that was researched and put on the map, and then we could deal with it. Guys, if we could prove that we slowed down or prevented degeneration with some level of certainty and could at least slow it down, I mean, we'd have something for actually proving this kind of anyways, I'm getting on a soapbox here, but I get excited about this stuff. That's why osteitis condensans iliae is an important diagnosis. Okay, questions on this? I got 7 minutes or so to cover 2 more cases for the purpose of the quiz. Let me move on here.
I think Jeff just checked. I think somebody might have had a question.
Yeah, hit me. Anybody? I didn't hear it. I'm sorry.
What part of the sacroiliac joint, the upper or lower, bears most of the weight? It's the upper, right?
Which part is the most involved in this case, or what did you say that one more time?
Bearing the loads of axial weight bearing. The upper is majority of the axial load, right?
That's a great question. The upper does bear, the upper and middle bear the most weight, but watch this, and that's why you're seeing the sclerosis pop from the middle portion of that joint. On the other hand, the lower 1/3 or half is more of a joint. And so that's where you're going to get your micromotion and your abnormal biomechanical loading on the joint itself, which is going to give you a stress-related movement changes. So you're going to see the sclerosis in all 3 compartments, upper, middle, and lower, because the lower has the joint and moves, which causes Wolff's Law, that yes, the middle and upper bear the brunt of the load. Does that make sense?
Sure does. Thank you.
You bet. Any other questions on this case? Great case. Great case. Chiropractic case. All right, let me give you a couple extremity cases, or one extremity case. Here's a 35-year-old female who fell on an outstretched hand. Okay, this is very recent. This is last week. All right, so fell on an outstretched hand and has significant pain in the scaphoid and in the distal radius. All right, anybody see anything in the scaphoid or distal radius?
Scaphoid fracture right through the mid portion there, possibly. And then maybe even a distal radial fracture there with that buckling right in there.
Okay. All right. Let's talk about this. That's good. It's really hard to tell, if that sclerosis through there is an impaction of the scaphoid. I think it's tough, but it did hurt there. So remember, on these, you want to get P to A wrist, ulnar deviation with 30 degrees of tube angulation. You want to we got to have a better view if we're going to see the scaphoid. That's called the scaphoid view. This is the scaphoid view. P to A wrist, P to A ulnar deviation, and instead of shooting it right through the central ray, angle the central ray towards the elbow, 30 degrees. And it really elongates that scaphoid, makes it look really long, easy to see. But I'm with you. I'm not 100% about the scaphoid, but I do agree about the distal radius. Now, that little bump's normal. But I think you're right. Now, just look. Everyone look at the distal radius here. Look at the distal ulna. Okay, now look at the distal ulna. I mean, it's beautiful. It's homogeneous, really homogeneous There's no, but now look at the distal radius. It looks like there's an area of increased, kind of hazy, increased linear opacity going across. Take a look at it. Do you buy that? Now, let me show you the lateral view. Let me blow this up. Take a look at the lateral view. Look at the dorsal aspect there. Look at the dorsal aspect. Do you see anything? On the back side of that wrist. Is everyone still here?
You can see the fracture line all the way through.
Yeah, and let me, right at the very back of the radius. Now take a look. I'm gonna go like this and circle it and outline it right there. There's a separate ossicle right back. There's cortical offset. Now let me blow it up so you can see it. See that? I'm like, what in the world? There's a cortical offset there. So if I go back, that really lends credence to the fact that, yeah, you know what? There's a fracture through here. I thought that was pretty dang subtle, but I'm pretty convinced of it. We're going to go ahead and get an MRI to see how bad it is, and we're also going to, that'll help us rule out a scaphoid fracture, because I agree. I don't know if it was Dr. Wayne or who questioned that fracture there. So, guys, the most common fracture of the wrist, and this might show up somewhere in a little quiz coming up. The most common fracture of the wrist is the scaphoid fracture. So you cannot, if they have pain in that snuff box, you've got to take a scaphoid view. These are almost impossible to see without the scaphoid view. And if you're not certain, spend some money and get an MRI. These don't heal if you delay. They don't heal very well. So we're going to do that. All right, good. Good feedback.
Yeah, that distal radius, though, I mean, that wouldn't need anything more than just letting it heal, would it?
Yeah, that's a great question. Now, because there's not displacement, there's hardly any angulation, they'd probably cast it because it's a big bone and it's impacted. It's impacted, I can tell, because of the sclerotic bone right there. And so it's squished together. And so my point is this, it's going to hurt like crazy. So if they'll probably just cast it, or somebody, if it depends on state by state, if you have the ability to cast bones as a DC, you just look up your statutes. But I'm saying it probably needs to be protected, not because it's going to mess it up, but it's going to hurt like crazy just bumping it. But I would probably get an MRI and do more here. Let me tell you why. Okay, hallucinate with me if you will. Everyone, grab your coffee. Take a sip. And look with me. Look there. I think there's a lucency heading into the joint, an intra-articular lucency into the radial carpal joint. Take a look. Let me draw it in. Right there. Right there. Now I'll erase it. All right, and let me expand that. You see what I'm seeing? Anybody? Bueller? Guys buy that?
I buy it.
Okay. Thank you. I just want to make sure I'm still with you guys. Very good. So I think it's going to be okay, but because of that lucency, I wanted to get an MRI and see how bad this is. All right, next case, last case, and then we'll see if there's any questions. I want to get you guys, it's supposed to be lunch and learn, not the whole afternoon. So 60-year-old female with history of MVA. Okay, the most common carpal bone to fracture is the scaphoid. Next case, this is a great case. 60-year-old female with a history of a motor vehicle accident. All right, everyone take a look at this. Is there a compression fracture? Yes or no?
Yes.
Yes.
Okay,
Yeah.
good. So everyone's saying yes, and I agree. And I think you're all seeing right there. Is that what you're seeing?
Yes.
Yeah. Now, watch this. I'm going to give you the AP view. And of course, we can ask, is it acute or chronic? We can ask, is it stable or unstable? Is it aggressive or non-aggressive? But look at the AP view and see if you can slam dunk the diagnosis on the AP view. Take a look at T5, which is the level of that compression on the lateral view.
Hemivertebrae.
Butterfly.
Okay, really close. Hemivertebra is close, and in fact, this is a butterfly vertebra, but butterfly vertebra, all that is a symmetric hemivertebra on both sides. So you're right, but take a look at this. That's cool. All right, now maybe only cool if you're a radiologist, but that is an awesome butterfly vertebra. Just came through last week. And so, guys, what's cool about that is it's not a compression fracture. And that, of course, helps you in your follow-up. But here's the deal. But here's the take-home lesson that you might see again. A butterfly vertebra always mimics a compression fracture on the lateral view. That's huge. Because I've seen probably 20 butterfly vertebrae in the last 20 years. You're going to see this. A butterfly vertebra mimics a compression fracture on the lateral view. All right. Questions on this case?
So a butterfly vertebra, we never had that term when I was in school in the last century. I mean, but a butterfly vertebrae is a bilateral hemivertebrae, right?
Yes, it is. You got it. Yep. It's a congenital/developmental condition, just like the hemivertebra that you brought up. And so it's not a traumatic compression fracture. It's wedged, but it's wedged developmentally or congenitally. And that helps you, of course, in how you treat and how you adjust and if you adjust and heck, all kinds of stuff. So I thought it was a cool case. Any other questions?
Does that area potentially come with increased problems or symptoms over a person's lifetime, or is unrelated?
Good question. Basically, that area will be just as stable. The bone will be just as strong. Everything you can probably adjust right on that segment. Here's the only thing that I would say, the complication, is that when you have congenital anomalies of the spine, you can also have cord anomalies. Now, not all the time, but congenital CONG can lead to CORD. That's how I learned it. So if you have a nasty congenital anomaly, it's not nasty in the sense that it's unstable or you can't adjust it or it's anything like that. But if you have congenital anomalies of the bone, you can have congenital anomalies of the cord. So you could have maybe Arnold-Chiari or a tethered cord syndrome, or probably not a diastematomyelia or anything weird like that, but you can have things like that. And you can also have organ abnormalities. So I think a good review of systems, a good history, a good review of systems is in order if you have a butterfly vertebra, but I don't think it really impacts how you would treat the patient as far as adjusting. Good question. Other questions?
I guess I have a question from a previous case, but if we're still on the butterfly vertebrae here.
No. Yeah, hit me on anything. I'll try to answer it.
Okay, the tube tilt on the scaphoid view, can you explain that, exactly how that's oriented?
Yeah, I'm back on that picture. So you would do a P to A wrist view just like we have here. Okay, I'm going to get rid of that there. But you would do ulnar deviation, right? P to A, with ulnar deviation. But the key is, instead of just shooting the x-ray right through, right through, no tube tilt, like we normally just put the X marks the spot right in the wrist, shoot straight down without any tube tilt. But instead, what you need to do is put the X mark the spot here, but tilt the tube 30 degrees towards the elbow.
Okay.
Does that make sense?
Yes.
30 and if you do P to A, ulnar deviation, 30 degree towards the elbow, I'll tell you what, you guys will be writing me thank you notes. You'll be sending me Christmas presents, because you'll have a lot better shot of getting your wrist cases right. Good question. Other questions? We have 2 minutes. Other questions?
You prefer nuts or fruitcake?
Fruitcake is good. I like nuts. Anything like that is good. I'll eat it.
I appreciate the review. It's wonderful.
Great. I hope you like the cases. I love doing this, guys. I'd love to keep coming back just to give you little shots of real radiology, and I'll show you fresh cases that are hot off the view box and discuss it. We'll get better with Zoom so we can talk more. But and if there's any kinds of cases that you would like, let Jeff Smith know, and I'll try to bring some specific kinds of cases too. But I love just talking about, good cases and doing case studies instead of just lecturing at you. So thanks for your time. My advice is to take the 6-question quiz if you want the hour of continuing education now, because it'll be like taking candy from a baby right now. But of course, if you wait for 6 weeks or 6 months, I can't promise you anything at that point.
Thanks a lot, Dr. Rich.
You bet. You bet. Jeff, any last comments for me, Jeff Smith?
I just want to thank you again. This is great. It's adding your drawings and notes in there is exceptional. So very happy with it. I will be sending out again. I'll be sending out an email that will have a link to the video as well as a link to the test, and it'll be out here probably within the next hour or two. And Jeff, we look forward to seeing you back again in April. So
all right, I'll be here. I'll be here. Take care, guys.
Jeff.
All right. Bye-bye. Bye, Jeff.